syndrome. What was the thing I said it was also called? ITBS, iliotibial band syndrome, iliotibial friction syndrome, iliotibial syndrome. It has like so many names, right? Or just plain old IT band syndrome or IT syndrome. Okay, so don't let that throw you off. Make sure you understand your terminology when you're reading the questions on PANCE, because they like to get tricky sometimes and use these abbreviations that are sometimes commonplace, but sometimes are not. Okay, so iliotibial band. This is getting into some of the lab stuff that we won't cover today unless someone says something. But we'll talk about some anatomy stuff. ASIS, anterior superior iliac spine. I did mention that in your MSK radiology anatomy review, correct? Okay, so ASIS, you must know what that is. You should know what that is, right? And then Gerdy's tubercle, right? Because that spans from where it originates to where the IT band inserts, okay? So Gerdy's tubercle, is that lateral or medial? That is lateral. So this is lateral-sided hip or thigh pain, correct? So that's usually what people are going to report. So, and what does it do to? Again, I think that friction syndrome, that's where it comes from, right? It can be overused friction, okay? And it's important to understand that when you're talking about it being lateral, when you have the knee extended or flexed, that is the position of the IT band is either going to be anterior or posterior to the what? The condyle, correct? Okay, so when it says there, condyle, it says lateral femoral condyle, right? So make sure we're on the same page about that. So extended, it's going to be anterior to the condyle, and in a flex beyond 30 degrees, not just flex, but flex beyond 30 degrees, it's going to be what? Posterior to the condyle. So do you think that when a patient extends and flexes their knee that they can report pain? Yes, and they can also report snapping. We did talk about snapping hip syndrome, correct? So that can be a component to this too. So that's why when you're talking about snapping, especially if it's proximal, you really have to get a sense, is this iliopsoas or is this IT band? Does that make sense? So you have to kind of zero in on that. Okay, and these are things you need to start thinking about, because with the IT band you can have pain and reverberation from either proximally or distally. It could be anywhere along that tract. Okay. Now, if it's insertional pain, then we're talking about Gerdy's tubercle pain, correct? Okay. If it's originating pain, meaning it's from the closer to the origin, it may be more hip pain. Okay. You would agree that the ASIS is found around the pelvis and the hip. Okay. So what kind of population are going to come in and tell you that they're having these symptoms? What does it say there? Runners and cyclists, right? Long distance runners, especially. Okay, so this can't be an overuse type thing. All right, so it's important when you're reading your PANCE questions, they usually tend to kind of give you a little something, a little nugget of, hey, this is the patient population that you're talking about. Okay? Everybody sees on that picture there where it says site of pain, so that would be insertional pain, correct? But again, can they have pain all along there? Yes. Okay? All right, so symptoms, pains, anterior lateral aspect of the what? The knee. Okay? But again, like I mentioned before, hip pain can be knee pain can be hip pain. Guess what? It can all be back pain, so that you can get it complicated quick. So the patient will describe that it worsens with running, especially downhill, because they have to do deceleration, do more muscular contraction, okay, more force, and what? And cycling. Okay, I actually did my my studies as an exercise physiologist in cycling, so I can tell you it's real. Okay, a lot of cyclists have this condition, so at some point. So they may report an audible pop laterally, and again, it's something that they say they can hear it. Has anybody in here had IT band syndrome? Yes? Did you have snapping? No? So you didn't hear anything? Okay. So his was inaudible. Okay. Did you do physical therapy for it? Did you have hip pain? Tightness, right? Yeah. And that, he just hit it. Thank you. So IT band a lot of times is tightness. Is the over test a test for tightness?
Yes.
Well, yes, right? Okay, so they have tightness and or pain. So usually if they have tightness, they have pain, correct? That's kind of the source of why they're having these symptoms. So you think a good conditioning program incorporates hip and knee exercises? Absolutely, 100%. Okay. See, he's contributing to the lecture. I should just do that thing where I do the flipped classroom, and you guys come up here and tell me about this. You guys love it. Yeah, I'm being recorded. I'll be nice. All right. So where's the tenderness of palpation? So if you look there in gold, I think it's yellow, but it's supposed to be gold. It says where is the pain? 2 to 3 centimeters proximal to the lateral joint line. Why is that important to distinguish? Well, we did talk about how if you have medial sided pain, it's important to distinguish whether or not it's along the MCL or it's at the joint line, right? Because can the differential be different? Yes. So key in on that, okay? 2 to 3 centimeters proximal to the lateral joint line. Okay, so it's not necessarily joint line pain. You guys saw that red explosion here in this picture? That's what that's telling you right there in that picture. Okay? So over again, tightness and or pain. If they have pain, I report it, but if you have tightness, that's a more significant finding because that's usually telling you, hey, this is why they're having this issue. Okay? There's your picture supposed to demonstrate that over test. You guys told me last class and you guys are good with that. We'll see. Okay, we'll practice. And I'll show you a better way of doing it, okay, if you haven't already been taught. Make sense? Of course it does. All right, so if you don't do anything about it, what happens? Well, they have decreased activity. Do long distance runners and cyclists like decreased activity? No. So they'll come back, don't worry. If you don't address it, physical therapy doesn't address it, they'll come back. And therefore, if they have decreased activity, they have a lower fitness level. That makes sense. Non-operative, that's your standard now. And it says rise activity modification. You guys should be able to recite that out of a dead sleep by now. Okay? Ortho is all about that for non-operative care. Corticosteroid injections, they can be done. Okay? I wouldn't do them initially because we talked about this before. If somebody comes in with pain and you tell them to go to physical therapy and do the exercises and all that stuff, and you give them an injection and they get 100% pain relief, do you think they're going to do the exercise?
No.
Not always, right? So I say that you should choose your injections judiciously. Okay? And again, depending on where their pain is, you might not be able to kind of nail down one spot, right? So you don't want to just go digging around the IT band or the tensor fascia lata, right? It's not a fishing expedition. So just be judicious with that, okay? But your book just mentioned it, so I will too. Operative, few options, very rare. Very rare, okay? So really the only thing you can do, think of the IT band as a band, right? It's a band of muscle and tendon. Okay, and if you have tightness along it, if you put a little nick in it and stretch it out, right, do you think they're going to have less tension? Yes, but then everything that comes with that, you also inherit, okay? Because the IT band does contribute to some extent to lateral stability of the knee. So depending on what you do, they may have some degree of other issues after you perform an IT band lengthening. We won't get into the surgical stuff. Again, very rarely done. Okay, so what do you think the focus is? Again, making sure that they get the appropriate amount of physical therapy and that they're compliant. Okay. So what are the things that can be bad with treatment? Well, if you do injections, especially if you do them with poor technique, infection, right? That's always the case, right? And that's cumulative if you do multiple injections. IT band weakening. So again, if you're just kind of shooting into a barrel and you're just kind of going here, there, and everywhere, that corticosteroid injections run the risk of weakening of tendons.
Yeah.
Yes. So especially if you're doing it around Gertie's tubercle, okay, you can weaken that insertion, and then you can actually cause an issue. Okay. So again, be careful with what you're doing. Sub-Q, fat and skin atrophy after injections, and that is again cumulative. If you do multiple of them, you may have more of that breakdown of the adipose tissue and blanching of the skin. Everybody good with that definition? We all know what we're talking about? Okay. So, why do you refer? Well, you refer because you've done physical therapy for quite some time. You've done all the non-operative stuff, you've modified their activity, and you just don't know like what else to do, okay? We don't get these referrals very often because, like I said, surgery is rare, right? But if you get to that point, you refer. So if you are in the course of either your initial assessment or subsequent assessments and monitoring, we call it surveillance, right? You're not spying on them, you're just watching them, right, over time. So you find that they have ligament or tendon insufficiency. Everybody's good with insufficiency. We know what that means. Okay, it's not sufficient. Okay, going back to ACLs, do we sometimes say ACL insufficiency when somebody has a complete rupture? Yes, it's not sufficient in the case of the ACL to provide resistance to anterior translation. Same thing with the IT band. If for some reason you have weakness, we may have to do something about that. Okay? Any questions about IT band? Okay. Gastrocnemius tears. So everybody knows that your gastrocnemius is your cap, correct? Gastrocnemius soleus complex. All right, so we know that it's more than just a cap. It's in the gastrocnemius, excuse me. But we don't focus specifically on gastroc tears. Okay? So when we talk about gastroc tears, it's just what we talked about before. I think we might not have mentioned it, but the cap has how many muscle bellies? 2 muscle bellies, medial and lateral, correct? So the key player here is medial. You guys see the redness there? Medial sided. Okay, that's the right side, correct? That we're seeing there? The patient's right. Okay. So it's also known as tennis leg. I threw that in there because your book mentions it. I don't know that I've ever actually said that to a patient, like you have tennis leg, but it kind of gives you a sense of like the population, correct? So if you want to remember it, that can be helpful. Where's the most common tear? I just mentioned it, medial head. You need to know that. Because if somebody presents with lateral head gastrocnemius tear, then that means that probably the medial head and the lateral head are involved, correct? So that can be more significant. But the most common is a medial head, okay? And it's at the musculotendinous junction. It's literally what it shows you there, right? Where it's the junction where the muscle meets the tendon, okay? What tendon is this, guys? Achilles tendon, okay? Does that predispose them to having some kind of Achilles tendon issue? Yes, right? So it's important to understand that usually the pain is going to be, the injury is going to be, and the pain, is going to be at the musculotendinous junction. And what patients get this? Greater than 30. I told you guys already that when it comes to musculoskeletal injuries, when you hit 30, you're old. Okay? I just insulted half the class. But it's just because over time you lose your flexibility, right? So you can be more predisposed to these injuries as you get older. So if I say 30 is old, then chronologically, then I'm like, God, I'm being recorded, I can't say that. But I'm the old dude, right? So, but greater than 30 is your number, okay? So if you've given a scenario with a 34-year-old male who does what? Plays tennis, okay? There you go, you're building towards something. And he has medial-sided calf pain, okay? So what does the patient report? They say they were out for a run, they didn't warm up, they're old, they're 31 years old, right? And then, see, now you're never forget it. And then they felt a pulling or a tearing sensation in their calf, okay? They have pain proximally and medially, right? So let's talk about this. Not the distal. Distal, we're talking about Achilles, right? Totally different mindset. But it's proximal and medial, so that's the medial head, at the musculotendinous junction. So you see the arrows there? Right there? Okay. So that's what you're going to see a lot of times, okay? Is that you'll see that ecchymosis. And we'll talk about it, but you may not see this ecchymosis right away, or the swelling, okay? But that's really going to report pain. So posterior medial, so posterior, right, and medial calf. Okay? That dude's got some red heels. Okay? So focus on the ecchymosis though. So when you do your physical exam, they're going to have tenderness there, just distal to the muscle bulk. So everybody understands what I mean by muscle bulk, right? So it won't actually be the muscle belly necessarily. Again, it's that musculotendinous junction, right? I lost one person already. So the ankle could be held in a plantar flex position, okay? And that could be something where they're holding in that position because when you plantar flex, do you take tension off the calf? Yes. Point your toes down. No? Okay, so this is due to what? Potentially a significant tear, right? So you have to pay attention to that because when you see the patient in a certain position, just understand that they may actually be related to the actual tear itself. So they're unable to maintain that normal tone there, and therefore a posture where the foot could be held in a more neutral position, okay? So then you're questioning it, you ask the patient to do a single leg raise and they're unable to. Okay? You would agree that you have to, with your calves, you have to do this, right? So, okay. All right, so if you're unable to do single leg, because if you do double leg, or both legs, will the other side pick up the slack? Yes, so this is a single leg thing. Okay, it's too early in the morning to demonstrate, I'll fall over, and I'm freezing. But this picture here, what it's supposed to denote to you is that this is a patient that presented, this is actually a famous athlete, okay? I can't pronounce his name, so I won't even try. But he basically sustained, right, not suffered. We don't use the word suffered in orthopedics, we say sustained, right? Suffered is something ER guys say. We don't like to make our patients suffer. So, if you look there where the red circle is, it looks like there's decreased muscle bulk there, right? Of course it does, because it's circled in red. So that's what you're seeing there, okay? So that could be a sign that it's been present for some time. Because if the patient A has a significant tear that's chronic, or has a tear where they didn't seek treatment for it, do you think if they don't use it, or, you know, it's that old saying, use it or lose it, that they could get atrophy? Yes. Okay, so that's what that picture's showing you. There's significant atrophy. If you look, this dude's got some pretty big calves, right? If you look, what's that? Not as big as yours, Brown? Okay. Yeah, or actually, I know you guys are like partners in crime over there. But so understand that when you're looking at your physical exam, it is important to take a look and see. Let me go back to this. Take a look and see, compare muscle bulk side to side. Okay? Ask them to do single leg raise. If they're unable to, you're highly suspicious for a gastroc tear or something involving that complex that we just talked about. Okay? And we'll get into Achilles later. Are we good with that for now? Okay. All right. So when we talk about diagnostics, very rarely do we actually do MRIs, right? Because what's the most common? Medial head, right? Low grade, we're all good with low grade, right? That means like a grade 1, right? Low grade, all right? High grade means grade 3 or complete. Okay, so low grade gastroc tears, the course for this usually is rest and activity modification. We'll talk about that. But do you need an MRI to diagnose that then? No. Are you doing it on physical exam? Yes. Even though they have pain with a single leg raise, they're able to do it. So if it's a low grade, then that means that you can slow down and he doesn't need surgery, right? He or she. But if you're thinking it's a high grade, so if I saw this picture here, I get an MRI. Okay? So maybe consider though, an MRI can be considered if the diagnosis or the extent of the injury is unclear. Okay? So do you think sometimes with these type of injuries, especially if they're chronic and scarred in, that we might have to supplement and add length? Yes, we talked about that before, right? Soft tissue augmentation. So it's important. An MRI can be helpful in that case. Does everybody see where the tear is here and here? Okay, well guess what? You've got tears over here and over here too, right? So what view is this? Just axial view? Okay, good. So you, as you scroll up and down, you can see the extent of the pathology. So that's where it's helpful. Okay? Makes sense? What's the S denote? Soleus, right? So again, you're trying to see what's going on. There is a soleus tear, can mimic a gastroc issue. We won't get into soleus necessarily, but soleus can be the thing that can kind of confound things a little bit. Okay? So you would agree that the soleus is more deep to the gastroc, right?
Yes.
So if somebody has just an isolated soleus tear, it can mimic the gastroc. But will the patient have potentially a defect there where you can feel, or that ecchymosis superficially? No, right? So if it goes on to persist, okay, and you don't get any resolution, then you can get shortening of the tendon, okay? Then you can have chronic pain, obviously dysfunction, re-injury, all right? So if you don't slow down and treat this, as we know in the NFL, when running backs, other players get certain injuries, they have to take some time out, right? So that's important for this as well, is to make sure you tell your patient, hey, I understand that you like to play tennis, or that you like to run, okay, but you're gonna have to slow down because you can re-injure it, or if it's a tear, can you cause further propagation of the tear? Oh yeah, you said it with authority. Okay, so you can get a DVT anytime you have an insult around that area, and especially if you have decreased mobilization, right? So it's more sedentary, then is that a risk factor? Yes, Berghaus triad, right? So, all right, so non-operative treatment, that's the mainstay. Okay, I'm not going to read that to you. But if you put a patient toes down with a heel lift in a cam boot, do we know what a cam boot is? You guys seen the cam boot? You see Dr. There's a person walking around that has a cam boot on. So it's that boot that you guys have seen, right? And so it basically comes up just below the head of the fibula, and it doesn't allow what? Well, cam stands for what? Do we know? No? Okay. So a cam boot basically will not allow ankle motion. Okay? So that's where the A and the M comes from. Okay? Continuous ankle motion. Brace. Okay? So what it does basically is it doesn't allow patients to either plantar flex or invert, evert their foot. Okay? So if you put the patient in a cam boot, they're going to be at 90 degrees. Right? That might not necessarily be the most comfortable for a gastroc tear. So putting your toes down would be better. So what you do is you take a cam boot, right? You unstrap it. You get some heel lifts. We know what heel lifts are? Just the paddings, the wedges we call them, right? And it basically puts more pressure on the heel and puts the toes down. Okay? That's in the cam boot. So that could be more comfortable to relieve that tension on the calf, on the gastrocnemius. Make sense? Okay. So that's why it says cam boot with a heel lift, right? Compression sleeve, we always talk about right compression. That's part of rice, right? So compression could be everybody's seen those sleeves that some people wear? Okay, sometimes they wear them without injury, right? Why is that? Well, some people say it helps with power, right? We have a strength there, right? So, but also that it can mitigate some level of injury as well. Okay, so, but in this case, the compression not only will it provide decrease in swelling, but it can also provide pain relief. Okay, we talked about how changing the working length. We talked about the straps, right, for the forearm. For what condition again? Epicondylitis. Okay, it can provide relief. Same thing with this. Okay, so compression is something we use very commonly. What's a simple way of doing compression? You don't have to go buy those. I always say Lance Armstrong, which he's disgraced, right? But pick another athlete, right? They have to use one of those things that are like endorsed. You can literally use an ACE wrap. Okay, You put the appropriate amount of compression so the patient feels that they're getting some level of support, but that you're not cutting off blood flow to the distal extremity. Okay? So after you put a compression sleeve on, do you do neurovascular checks? Yes. Right? So that if you tell the patient, because very commonly they'll do it themselves, say, if you can't feel your toes, it's too tight. Okay? Good to go? Can you compress the peroneal nerve as well? They could have foot drop? Yeah. So just make sure you give them some level of guidance if you're going to be doing this in clinic. All right? But they can return to activity in how many weeks? 6 to 8 weeks. Right? 6 to 8 weeks. So that's a good amount of time. So good luck telling your patient that likes to run or, God forbid, CrossFit, right? CrossFit was invented by orthopedics, right? I swear. Anybody over the age of 30 that does CrossFit, they're our favorite patients. Okay? I know, 30, right? That's so old. But how many weeks? 6 to 8 weeks. And I mentioned earlier, large tear, palpable defect. We'll talk a little bit more about that today with quad and patellar, maybe not today, but quad and patellar tendon ruptures. But basically what I mean by palpable defect is that when you go here and you put your finger into that area as you course proximally to distally, and you actually fall into the muscle belly itself, or at the musculotendinous junction, that's a palpable defect. Would you agree? Okay. So, but it's the medial head, right? That's the most common. So is there a lateral head?
Yes.
Yes. So the weakness may not be as profound. There are some ways that we do in orthopedics to kind of try to isolate some of that, but it's not exact. Okay, but again, if it's a large tear, I mean, it's obvious, right? Do you think this guy went on to have maybe some consideration for something? Yeah, maybe. Yeah, because he I can't say his name, but he is a high-level athlete, meaning crazy stuff, right? So maybe. But if any patient that has a large defect or a large tear, palpable defect, they'll get a consideration for surgery, okay? So can you get compartment syndrome due to an injury and subsequent swelling and compression of the structures in that compartment? Yes. Okay, so if you have a concern for compartment syndrome, is that a surgical emergency?
Yes.
Yeah, so just be aware of that, okay? So how fast do you refer them? Like right now, urgently, okay? Of course, treatment again, NSAIDs, it comes up a lot, right? Make sure you're not just giving them willy-nilly. So, loss of dorsiflexion, atrophy of the calf, and range of motion, and stretching exercises are not encouraged. So what that means is when you first send them to therapy, and remember I told you guys when you send them, you can put in your note what you want them to focus on, right? So you're going to tell them to do strengthening, range of motion, and progressive strengthening exercises. And if they don't do that, as you know, they don't kind of keep up with it as they're healing, maybe not the strengthening, right? The range of motion initially and flexibility, then they can actually go on to have more issues. Make sense? Okay, especially if they're over the age of what? 30. Okay, good. So referral decisions again, large palpable defect, as we said before. You feel it, you fall into that cavity, or that crater if you will, and you feel that defect, you need to send them, okay? Persistent symptoms, you're treating somebody for a prolonged period of time, they're not getting better. In fact, they seem like they're getting worse, and they get some level of atrophy like you saw in that picture, you send them, okay? And obviously concern for compartment syndrome. That's been on their red twice, right? So don't forget, just because like we focused on the anterior compartment syndrome as being the most common, we remember that? Sort of maybe. Can they get posterior compartment syndrome? Absolutely. Not very common though in the absence of some specific injury pattern. Okay, so we talked about anterior cruciate ligament tears. In acute ACL tears, which meniscus is most commonly involved? Medial. Okay, so don't let that throw you off. Okay, ACL, is it intra-articular or extra-articular? Intra-articular, right? And it's complemented by the PCL posteriorly. Okay, and we'll talk about that later. Right? But it's important to understand with ACL injuries, you really have to understand the treatment for this and this referral indications, because your patients are going to ask you, right? So I really want, if I could foot stomp even more, not making jokes about 40 out of 50 questions being about ACL tears, it's super important for you to understand that pathology, okay? What's the normal recovery for an ACL injury? I know that I told you it. So 9 to 12 months, okay? Significant amount of time. So guess what? Am I going to see them every week?
No.
No, but they might come see you every week. Okay, so you have some level of familiarization with, hey, this is just going to take some time. Helps you deal with that a little bit better. Okay, we talked about autografts versus allografts. I told you guys I wasn't going to focus on that, but just understand that what patients get surgery? Younger, active, right? Good. Younger, active. Okay, if I tore my ACL today, right, go into my office to resuscitate my hands after this lecture, right, then I wouldn't get surgery, right? And I joked about it, right? Thank you. She's our willing patient, or unwilling, either way. And I wouldn't get surgery. Do I want 9 to 12 months of that? What would I, to get to what? To being able to like get up in the morning and get to my car, right? Like, no, I'm good, right? But patients that are young and active, they're going to push for surgery. Why do we do surgery? Is it pain? No. Instability plus or minus pain, right? And I know that sounds kind of callous, but I'm just letting you know, if you have that conversation with a patient, especially if they have a partial tear, well, what's the most common tear? Complete rupture, correct? Yes, for sure. So I'm going to ask them their questions. So if they tell me they literally have no instability, I don't know what we're talking about, right? So just make sure you understand when you're doing your special testing, are those pain tests? No. If they have pain with it, yeah, you're going to note it. You guys are going to be family practice pain gurus, right? Pain, right? We don't really deal with pain that well because, well, we concentrate. I told you guys that, okay? Claudication, I did kind of like breeze over that a little bit, but I did tell you guys it is important to study that, okay? Pants loves to ask questions about neurogenic versus vascular claudication. That's the reason I gave you guys that chart. That way, when you're going and studying for your pants, maybe you'll pull that chart out, right? Probably not. You'll disable your Canvas account by then. And be like, forget it, I'm never looking at that again. But that's why I gave it to you, okay? Do people with neurogenic claudication have wound healing issues? Not according to that chart, correct? And do I disagree with that to some extent? Yes, but I'm just saying when it comes to studying for pants, they tend to kind of hit that chart. Good to go? Okay. Neurogenic is stenosis or some kind of compression, right? And vascular, well, is that arterial or venous? Arterial, right? And I told you guys venous insufficiency is different, correct? That's those roly-poly veins that you can see on patients. They have venous stripping and all kinds of stuff going on, right? Do we use elastic compression on if we suspect that the patient has vascular claudication?
Yes.
No. It's on the slide. I got you guys again. Sweet. I'm 2 for 2. Yes. Because it's a venous issue. Okay? Make sense? So don't let that throw you off. I'm sorry. If it's a venous issue, then use elastic compression. Yes, thank you. Yeah. My brain just warmed up. Yeah. So what we're talking about is arterial vascular claudication, correct? So if you cause more compression on the artery, is that bad?
Yes.
Yes. Okay, so don't do it. Okay. IT band syndrome, we just went through it. I do think it's important with IT band that you understand your anatomy, because again, depending on where their pain is along that, it's a long distance, right? Yeah, from the ASIS to what tubercle? Perfect. Okay, so depending on which you treat, are we going to inject corticosteroids into the mid-substance of their muscle? No. We do other injections, let's not go there. what he knows about PRP. It's not currently in my curriculum. I would love to start teaching it, but it's just not fair at this point to change gears. But we all aware that PRP injections, right, are done out there, especially a lot in the military. I've done hundreds, and I lost count. So, but gastrocnemius tears, understand that again, we're looking for that weakness, that single leg raise. We're looking for palpable defects, because that's going to drive your decision making, right? If it's the run-of-the-mill, which head? Medial head, then you can treat that, right? Don't send that to me initially, right? You treat that. You can handle that, right? And make sure you understand that the way you can get the patient moving a little bit faster is to use compression. I use it a lot with these kind of injuries. Calf injuries and compression are good things. And it doesn't have to be anything too expensive, okay? Any questions about these topics? Okay. I don't know about you. This is push. So, knee pathology. Now we're going to start talking about meniscal tears. Okay, when we talk about meniscal tears, this is something where, again, I don't want to fly through it, but we'll take our time with that. Osteonecrosis of the femoral condyle, patellar quadriceps tendonitis. Notice that it says tendonitis, and then below it says ruptures, right? So that's a spectrum, right? So let's make sure when we get into this that we understand what end of the spectrum we're on. Is it tendonitis or is it a rupture? Patellofemoral maltracking, I hate that term because it includes so many different things. We'll get into it. And then we'll talk about patellofemoral pain, right? Everybody heard of PFPS? Patellofemoral pain syndrome, patellofemoral syndrome? No? If you go, when you guys become PAs, if you go somewhere where it's a training base, you're going to see PFPS every day. Right? Trainees, boots, right? They didn't prepare for basic training and now their knee hurts. Right? Atraumatic anterior knee pain is the worst in young people that are not old, right, and have arthritis. So, it's not the worst, but it can be challenging. So, meniscal tear. All right, so what is a meniscus? Those are those cups, right, those tissue that form a shock absorber between the femoral condyles and the tibial plateaus. Everybody sees these C's? Sees the C's. You can see the C, right? There's two C's. There's one here and one here, and then one here and one here. Which is the larger one? Is it medial or lateral? Okay. I think this is important to kind of highlight. So when you look at this, right, it says lateral right there, right? So I got you, but it's the medial. Okay? Make sense? Okay? So I'm pausing for effect, by the way. Because if you guys start looking at imaging in the future and you're going through and doing an actual cut and you're going up and down, right, the extremity, right, how do you know if you're medial or lateral? Well, if you see the bigger cup, I mean, the cheating is to see the lateral, see the fibula, right? Then you know you're lateral. Okay, but if you're just on the slice where you see the two C's, then if you see the bigger one, you know which one's medial. You know you're medial. Make sense? Okay, but the thing to understand too is that when we talked about joint space narrowing, which compartment were we talking about for the most part? The medial compartment, right? So that is a side of your knee that actually does a lot of weight bearing, a lot of load bearing. So you're designed a certain way, we are designed a certain way to maximize that load bearing. Does that make sense? Okay, same thing with this picture here. If you take it and you say, what is this right here, by the way? Yeah, that's tibial tubercle, right? Right? So you know that's anterior, right? So you would agree that if we say, okay, if you just take these C's and you cut them in half, okay, across like this, just go across, then you would say that there's an anterior and a posterior aspect to the C, correct? So the anterior aspect we call the anterior horn, and the posterior aspect we call the posterior horn, okay? So the reason I'm telling you guys this is because I got somebody that asked me a question, said, about diagnosing meniscal tears. It's more than just saying medial or lateral, right? When they come see me, I'm trying to figure out if it's anterior or posterior as well. Do I expect you to do that? No. But just understand that when a patient goes from a flexed knee to an extended knee, what's that test called? McMurray's, right? You guys are flexing, extending, and rotating, correct? And causing varus and valgus stress. Of course you are, because you're perfect at it. Okay? Don't worry, I'll teach you right. Okay? But just understand that when you go from a flexed and extended position and they're reporting pain, more pain or less pain, I'm looking at that as I'm doing my McMurray's. So my McMurray's might be different than the one you're doing, right? You're just doing it to see if they have pain and clicking, right? I'm looking to see what position they have pain and clicking in. Good to go? Because then I look at the MRI and I see an anterior horn, right? And I say, okay, I think it's anterior horn because based on their exam as well. Or they have pain in certain positions of flexion, okay? But tears disrupt the normal mechanics of the knee. Okay, did we talk about how meniscal tears can occur in combination with ACL injuries? Yes, okay, and we reviewed it as well. Okay, that's a primer. I think we should take a break because I'm already losing some people, and we'll push. Okay. All right. So of course, a really good question that I asked on break. And I want to share it with you guys, okay? Because I think it's important. So we talked about the cam boot, right? That large plastic-looking boot that we see people walking around in sometimes, right? When we put those heel lifts, those wedges, that is to put the toes down and the patient into a plantar flex position and to take the tension off the calf muscle, right? Do we do that very commonly? No. Because what's the enemy of orthopedics? Stiffness, right? So if we do a cam boot, I will tell the patient, you need to come out of this thing 5 to 6 times a day and do your stretches and your exercises and your motion. Make sense? So if you put them in a cam boot and they feel good, ooh, that feels good, right? Do you think they're going to want to come out of the boot and move? No. So very commonly we don't do that. Okay, but I just tell you that because that is a form of treatment that is mentioned in your book. Very commonly, like I said, what I do is I just do compression. And I tell them, I say, I want you weight bearing on this. You're fine to weight bear on it. Okay? The big thing though is you tell them don't do any sprinting, right? Dynamic activity. Because can you cause further tearing? Yes. Right? Did I get to your point? Okay. So cam boots are good, again, to take that tension off. Oh, and by the way, we talked about how it's a gastroc soleus going into the Achilles tendon, right? That's that whole structure there in the posterior aspect. Okay? So do you think we use cam boots a lot for Achilles tendon injuries?
Yes.
100%. What's the strongest tendon in your body?
Achilles.
Okay? So if you rupture your Achilles, that's a big deal. Okay? Make sense? When you walk around not being able to dorsiflex, plantar flex, dorsiflex, plantar flex, dorsiflex, plantar flex. No, right? So if we want to protect people, we put them in a cam boot. And we accept a certain amount of Achilles tendon stiffness, a certain amount, right? But we get them moving as soon as possible. So the principle still applies. So when you guys get to that next block, you don't see my face anymore as often, okay? Just remember what I said. Cam boots can be good, but they come with a set of risks as well that you have to account for. Does their DVT risk go up if you put them in a cam boot? Yes. Okay? Would you potentially put somebody on aspirin if they're going to be in a cam boot for a long period of time? Yes. Okay? Makes sense? So it all comes together, right? Okay. Go on. Any other questions about that somebody wants to wait to the end of the lecture to ask me? No, I'm joking. Sort of. Yeah, these are good questions, so I like to bring them up. Okay, so when we talk about the anterior posterior horn, that's where we left off. So the tears disrupt what? Mechanical. I should have put that in like super gold. Because mechanical is a word you need to associate with meniscal tears, meniscal pathology. If patients have mechanical symptoms, right? What did I tell you guys? Catching, locking, clicking. You need to think about meniscal tears, okay? Especially for pants, right? If they tell you medial and or lateral joint line tenderness and they give you mechanical symptoms in the scenario, you must consider meniscal injuries, okay? But in real life, you should consider it as well, right? Make sense? Of course it does. All right, so I added this, okay, types of meniscal tears. I thought that the previous slide deck didn't get this good enough. Am I going to ask you what the difference is between a peritic or a radial tear? No. Okay, but you have to understand when you're talking about tears, right? So this is the C's, right? You see the C here? Okay, each one of those C's. And then if you're looking here, that's looking at it from the sagittal plane, right? From the side. So that's trying to help you a little bit to understand, okay, if you're looking, you're slicing through from the sagittal plane, right? Left to right, if you will, or right to left. Okay, then maybe that's what you'll see on the MRI on the sagittal plane. Okay, but you do see here how there's longitudinal tears, there's radial tears, there's oblique tears, horizontal tears, and complex. Complex, do you think that's more significant? You could have different components of all those things I just discussed? Yes. Okay. The one I want you to focus on, though, for sure, okay, is this one right here. Pause for effect, and this one right here. That's a bucket handle tear. Okay? So you see how the C has been disrupted, and this flap of tissue is now free, correct? This flap of tissue here is now free. It's supposed to be down here and attached, right? It's supposed to be down here attached, but now it is a bucket handle tear. So it looks like a bucket handle. Everybody knows what a bucket is, right? Okay? So, all right. So if that piece of tissue flap there that's created, okay, for lack of a better term, although flap tear is on there just to confuse us, okay? So let's not use that terminology. So bucket handle tear is torn, the meniscus is torn, and that portion of the meniscus, okay, is now engaged in the joint itself. Can it cause a mechanical block to motion? Yes, because that tissue is now flipped. So when we use the term flipped bucket handle tear, it's flipped into the joint itself. We talked about that groove, right? That notch. Okay? If it's in the notch.
If it's horizontal, or like would it start off as a horizontal and then progress to a bucket handle? Or
Negative.
Kind of a bucket?
Usually it just goes straight to a bucket handle. Okay? And that's a really good question too. And I will answer that in 1 second. So what he's asking is, does it start as a horizontal and then progress to a bucket handle? Not normally. Okay? But getting back to what I was saying a second ago, when we're talking about these tears, it's important to understand that if the meniscal tear, the meniscus, is torn, that segment that is torn away from where it came from, right, is flipped into the notch, then when they go into flexion extension, they may have issues where they feel that their knee is catching, because that tissue is now causing a mechanical issue with flexion and extension. Make sense? So if that tissue gets flipped to a certain extent, right, and it's a significant amount of tissue and it's wedged in there, if you will, do you think sometimes it'll lock? Yes, so locking is again, it's catching and there's locking, right? So it's a spectrum, okay? So sometimes people, when they have chronic bucket handle tears, right, they will come back and say, well, I'm able to unlock it myself. They literally will do this kind of thing where they twist their knee. Is there a test for that that's very similar to that? It's a Thessaly test, right? So they'll do a self-Thessaly to unlock themselves, okay? But if you get somebody who has a bucket handle tear on physical exam, right, you need to call somebody, okay? Because especially if it's locked. Because is that something we want to get to surgery sooner?
Yeah.
Yes. Okay, now getting back to your questions. I want to make sure I answer, what was your question specifically again?
Yeah,
Yeah.
like you could, horizontal could progress.
Oh, yes, I remember now what I was going to say. Thank you. Every once in a while I just need that at my age. But a little bit of memory jogs. But, so, usually with a bucket handle tear, is it significant mechanism of injury that makes it happen?
Yes.
Yes. So usually you don't get those progressive tears like that. Okay, usually with these other tears over here, while they can also be acute, those will propagate. A bucket handle tear, usually it's a significant amount of trauma that occurs where it causes that shearing and therefore that extension. But it's not just a horizontal tear, right? It is a complete bucket handle tear. Make sense? Okay. Do you guys have any questions about these slides? I provided this one on the right specifically. It was not in there before because it doesn't even mention bucket handle here. And then I tell you guys, make sure you know that. And then there was no picture. Okay. You guys like pictures, right? Okay, perfect. Me too. Clinical symptoms. So report a twisting injury. Okay. So what does McMurray try to do? Tries to twist and create varus valgus or be create, right? So they report a twisting injury. Can you get ACL injuries the same way? Yes. And so that's why commonly they exist together. But again, getting back to that, can you play, can you not play? Have you guys picked up on that yet? That it says it on multiple slides and different pathologies. Are they able to continue playing normally? Yes, unless it's a bucket handle tear and they're locked, or catching and or locked. Okay, so they are able to continue playing. Make sure when you're reading questions in a few weeks that you're reading questions all the way. Okay. Pain worsens with twisting and squatting activities. Remember I told you guys, depending on what level of flexion or extension the knee is in, it can engage the anterior or posterior horn. So not necessarily a bucket handle tear, but if they're in flex position, right, meaning like a squatting position, okay, they may report more pain, kind of this vague pain, but more so in the back of the medial aspect of the knee. Maybe it's a posterior horn tear. Okay, maybe, who knows? Okay, but they'll always have mechanical symptoms, right? Yes. And when you hear mechanical symptoms, you think meniscal tear. Okay. Sometimes do we get MRIs for people that have arthritis and we see chronic meniscal tears and they don't have mechanical symptoms? Yes, sure. But for the purposes of this lecture, I want to make sure you guys don't miss that mechanical symptoms should key you into having that differential diagnosis. What's the most common horn? Okay, anterior horn. Okay. I don't know if this helps you. I might not want to say this, but when you go into a twisted and partially flexed position, do you think the anterior horn is more engaged?
Yes.
The answer is yes. Okay, partially flexed. Okay, remember we talked about 30 degrees as being kind of a number that gets thrown out there a lot? Okay, so 30 degrees is not that much flexion, correct? Okay. But in any regard, I won't ask you a question like that, but I just want you to see if you guys are thinking at 9:15 in the morning on a Thursday before a cardio test. Okay. Preparing yourself for junior clinical. Okay. But anterior horn medial meniscus is the most common. You guys are pointing at? Oh, yeah, yes, ma'am. They're pointing at you for you to ask a question, by the way. Okay. Yeah.
I'm not the ortho specific question, but so we're talking about all these like isolated things, but there's like that unhappy triad, right? The medial meniscus, the ACL. Does that change the way that we think about
No. No, and that's a really good question. She's talking about the terrible unhappy triad or something like that, ACL, MCL. I don't even teach that. So, and meniscal tear, yeah. Well, so what they're talking about there is that when you're doing an assessment on a patient, do you look at a patient, right, when you come up to Miss Bandy, right, and you say, hey, I believe you sustained a meniscal injury. Do you only do meniscal testing? No? For you, I would, because, you know, I got you figured out. But no, you don't, right? So you do all of those tests, right? And that's why, remember I told you guys, so when I gave examples of impingement syndrome versus other things, and I said, yes, there's a lot of common tests. They kind of bleed into each other, but it's important for you to take those tests individually and say, if I put this test result with this test result, then I get this diagnosis, right? And if I take one of those aspects or one of those components of that testing away, then I get a different diagnosis. Make sense? So same thing with this, okay? So you would agree, I think you would agree, I hope you agree, that if you do varus and valgus stress testing at 0 and 30 degrees, do you think sometimes you engage in meniscus doing that? Yes, but that's not the point, correct? The point is to assess the MCL and the LCL. Then what you want to do is you want to do flexion extension, rotation, and varus and valgus stress testing, otherwise known as McMurray's, correct? and then you take that component of it, okay? And then what was the other one? ACL, right? So then you do your anterior posterior translation. I teach this anterior posterior. I know your book says anterior, but we'll get there. And Lockman's, what's the most sensitive? Lockman's, right? So then I do a Lockman's test, and I'm like, ooh, I think I got an unhappy triad. Make sense? But ultimately, if you're thinking that bad, right, hopefully I'm answering some level of your question, do you think you're going to get an MRI?
Yeah.
Yeah, because usually if you have that level of injury, and we talked about this, do you have significant swelling as well if you're not able to assess them on the sideline?
Yes.
Yes. Right, so then you're like, I think I have instability, but he definitely has pain, right? So we may get an MRI. Okay? Make sense? Do NFL football players get MRIs on Monday mornings?
Yes. Yeah.
They do, right? Sometimes at night. Okay? But I'm just saying, there's a reason. Okay? Because you want to do the imaging before the swelling takes off. Can you have hemarthrosis? Yes. If you have blood in there, can you see it on an MRI? Yes. Okay, so it may cloud the picture, no pun intended. Make sense? Okay. Did I answer your question at some point? Mm-hmm. Yes. It's a really good question. I can go down that rabbit hole, but we don't want to do that. But hopefully you guys understand what I'm saying. So mechanical symptoms with joint line tenderness to palpation and deposited Murray's is a meniscal tear until otherwise proven. But this goes into the traumatic tears of the capsular attachment. I don't want to go there. I would tell you this. I would tell you that there, if you guys know about ramp lesions and other forms of meniscal tears, good for you. I won't test you to that level of detail. Okay? Right? What I do want you to know is that there is an anterior horn and a posterior horn, because you'll get reports, right? And you're going to tell yourself that which one's more common. Anterior, there, and you had a twisting injury. So I think, at this point, how do I treat them? And we'll talk about that. Make sense? Incarcerated fragment. What in the world are we talking about? Well, that's a bug handle tear, right? I said it was flipped, right? And it's incarcerated. Has anybody here been incarcerated that they want to talk about? No, of course not. You guys have all been through mess, right? Nobody's done anything. But you understand incarceration means jail, right? Okay, so it's incarcerated. It's locked in. It's jailed. Okay? Locked in is how I want you guys to think about it, because it's that locking, correct? Does that mean that they have limited passive range of motion?
Yes.
Absolutely, 100%. Okay? Again, let's get back to this discussion we had before about testing. If you tell a patient to do a motion that hurts, they're not going to do it, right? So this is a passive range of motion that you're going to do, right? So if you get a patient, and I'll go ahead and say this now, if you get a patient and you call me and you said they have a meniscal tear, I'm going to ask you guys, right? Or somebody like me will ask you, what's their range of motion? And you're going to tell me they have normal functional range of motion. And being that I taught you guys, I know you know what that means. Okay? Everybody knows that when you go home, right? When you're at home and you have to go to the restroom, that you have to squat down to 90 degrees or deeper, right? And yet when you stand up and you go to walk, you got to stand up straight, right? Put your legs straight. So 0 to 90 degrees is functional range of motion, essentially. Right? Does that make sense? So, do you want to go deeper than 90? Absolutely, 100%. But if for some reason the patient can't go from 0 to 90 degrees, or you tell me they're locked in at 70 degrees, I'm like, I'll be right there. Okay? Because I might have to come down and unlock them. Did I lose anybody when I was talking about unlocking a flipped bucket handle tear? I might have, because I hadn't talked about bucket handle tears yet, right? So this is what I'm talking about, putting it all together. If I come down and somebody's stuck there at 70 degrees of flexion, they're not leaving there, right, in that position. They can't, right? What's the enemy of orthopedics?
Stiffness.
Stiffness. They're going to get stiffness, okay? But more importantly, too, they're going to have shearing forces there as their attempt to continue to weight bear, and they can further propagate that bucket handle tear and make things worse. Make sense? Okay, so that's why I'm telling you guys. You'll call me and you'll say they have an ACL injury. I'm like, yeah, put the referral in. ACL injuries, I mean, they're big and swollen, right? What was the injury 3 days ago? Yeah, I can't get anything either. Put the referral in. But then I'm going to say to you, what does the rest of their exam look like? What's their McMurray's? Oh, and by the way, what's their range of motion? Make sense? Okay. So McMurray's, then we get into it, the painful click, right? So where do you put your thumb and your index finger and or your middle finger? On the joint line, right? So that's how you're going to feel that clicking. Okay, some of you guys have attempted to do McMurray's correctly, and you realize that it's not easy to do it, right? With some people, because they have big honking legs, or you're just not able to, you have small hands. I'll teach you guys some tricks when we get to lab, and how to do it on like big Marines, for example, you know? Use your body, use your leverage in positive mechanics to do a good exam. Because if you don't have your fingers there, because you can't support the extremity, can you feel the clicking?
No.
No. So it's not McMurray's, it's something else. Make sense? And then Thessalys, they're going to tell you with the Thessalys that they have pain at the tear. So when I talk about Thessalys, again, you put them into slight flexion, correct? You have them rotate, like stance, stance, stance. Okay? Anybody remember what that was? Okay. So they're going to have pain at the tear. You see these pictures here? That tells you everything you need to know, right? We'll get into it, don't worry. Okay. I know, some of you guys have been a lot, right? Have I lost anybody completely? Because we can't move on from that slide until we're on the same page. Okay? Nobody? Okay, because when the test comes on the 17th, you don't know that those concepts, you may struggle a little bit. Okay? Okay. So when we're talking about doing diagnostics, the important thing to understand with imaging of the knee, right? We haven't really talked about this yet, I saved it, is that all imaging we talked about should be weight bearing for lower extremities, right? Well, for knees, weight bearing is essential when you're talking about meniscal tears and ACL tears and whatever. So when you're doing weight bearing films, does that put stress on the medial compartment? Yeah. Okay, and we kind of talked about that already, right? So if you see certain things, like you see narrowing of the joint space, right? You can say, well, maybe they have more, what? OA, osteoarthritis. Make sense? All right? So you're getting somewhere. You're saying, okay, is this chronic? If they have a history of chronic OA, do they tend to have chronic meniscal tears? Yes. And they don't have a history of trauma. So you're getting somewhere. Can they still have painful clicking? Yes. Can they still have a positive Thessalys? Yes. But you're trying to get to a decision point, and we'll talk about treatment here in a second, okay? So MRIs, confirmatory tests, I know what you guys are thinking. Every patient that you see you suspect a meniscal tear, you're going to get an MRI. Maybe. We'll see, okay? But I'm just telling you that we use it for confirmatory purposes, right? Because if you look at an MRI, right, if you were to do an MRI of me, for example, I'll use myself as an example. I'm definitely over 30, okay? Do you think that the radiologist is going to comment about all my meniscal tears? Yeah, they get paid per word, I swear. Okay? So it's going to be this long paragraph of all this stuff, and you're like, but he doesn't have any painful clicking, doesn't have any catching and locking. He's complaining of something else, right? Do we treat MRIs or do we treat people? People. So don't get locked into that, okay? Don't just MRI for truth, okay? MRI for truth doesn't work, okay? Because you're going to find a lot of truths that are not true. But the patient's going to get a copy of the report, and they're going to be like, well, what do I do about this? And you're like, man, you don't have any symptoms that involve that, okay? So, make sense? Okay. Don't fall down that trap. Go do it a few times and you'll learn. Okay? Yes, sir.
Herniated disc, like one for me.
Yeah. So herniated discs. I mean, again, if you would look at my L spine MRI, they've been wanting to do a fusion IS spondylolisthesis, right? They've been wanting to do a fusion on me for years. And I tell them, I say, hey, don't you read the books, man? I don't have any particular symptoms that are pervasive. I don't have any weakness. I don't have any neurologic deficits. They're just licking their lips, right? A chance to cut is a chance to cure, right? So I'm like, nope, stay away from me. I'm that guy too, don't worry, but I'm just saying. Okay? So these pictures here, does everybody see the C's here? Okay? You see the C's here? Okay, which one am I pointing at right here, the big one?
Medial.
Medial, right? You would agree that now you understand that concept. So as you're slicing through there and you're looking for those abnormalities, that's what we're talking about. Okay? I know I'm taking time with this, but trust me when I tell you, it'll reap rewards when you're going back and studying on the 16th. Okay, finally studying on the 16th. Okay, so what happens? So if you don't do anything about it, they can accelerate cartilage degeneration. So you would agree that the meniscus is over the cartilage, right? Yeah. So if you break through the meniscus, then you're making contact with the cartilage. So you can have accelerated cartilage degeneration, and obviously more osteoarthritis. Okay. Treatment, non-operative, no mechanical symptoms, and degenerative tears. Unfortunately, with degenerative tears, and we don't really get into it too much, but there are zones of meniscus. Okay, there are zones in the meniscus that goes from the outside to the inside. Okay, and the vasculature changes depending on what zone you're in. Okay, so unfortunately, with degenerative changes, once they get to a certain point where they degenerate to a certain extent, even if you were to tack it back down, it's not viable. Okay, everyone understands that concept by now? I've been using that term. Okay, so sometimes you just have to go in there and whack them. Just take them out and get rid of those mechanical symptoms, right? Those little flaps aren't flapping anymore, aren't getting caught, aren't causing that catching. Are they going to have less pain? Yeah. Okay. And that's what we talk about. So I'm going to leave it there. Okay. So just understand no mechanical symptoms and or degenerative changes, right? Then we start talking more about some arthritis potentially as well. Okay. Make sense? Anybody ever heard the term scoping for dollars? Arthroscopy for dollars? Okay. When you get to a point where you have such bad arthritis, and you can see those little degenerative changes, we'll just go in there and we'll shave, we'll clean things up a little bit. Maybe somebody in here's had it done, right? And then we'll say, okay, that'll be $2,000, please. And then you come back in 2 more months, we get another MRI, and you say, oh, look at that little flap. I missed that sucker last time. All right, so then let's go scope that. So we call that scoping for dollars. Okay, makes sense? It's kind of funny, but it is a thing too. Okay, so that's what we're talking about. Okay, do they do that in civilian practice a lot?
Absolutely.
Absolutely, 100%. Do we try not to do it in the military population? Because even if it's functional meniscus is providing some level of shock absorption, do we try to leave it in place?
Yes.
Yes, because you guys are all high-level athletes, right, Mandy? Absolutely. She's just trying to stay warm. Okay. But you see what I'm getting at, though, right? So our focus in the military, especially, is a little bit different than the civilian sector. When you get old like me, they're always looking for reasons to scope for dollars. Okay. Operative, younger people, boom, right? Younger people that require that shock absorption, that stability to the menisci. And we talked about this yesterday. Yesterday? Yes, yesterday. Menisci, do they provide stability to the knee?
Yes.
They do. That's part of that secondary stabilizers we talked about yesterday, right? Okay. So that's something we'll do as well. So operative, locked knee with loss of passive range of motion. It is a bucket handle tear, at least a complex tear, right? But it's a bucket handle tear until otherwise proven. Good to go? Okay, peripheral tears, we'll try to repair them. That again gets into that vasculature thing. If they're peripheral, a lot of times you can repair them and they'll heal. Yeah.
Mechanical symptoms are saying if it's 90 degrees.
Mechanicals is snap, crackle, pop. The 90 degrees is just range of motion. Make sense? Yeah. Everybody count that? Okay. Large tears, there we go. Scoping for dollars. Okay, arthroscopic debridement. That's a fancy way of saying go in there and whack it. Okay, do we use special instruments that go into portholes that has a little shaving end? Yeah, we call those shavers, right, Priscilla? Ortho's the best. Okay. I know. So that's what the picture up here, that's a tear. Okay? This is where the tear is. You see it? This should look like this. Okay? And the same thing over here. This should just be a continuous flap of tissue going across. Okay? And you have an area where it's kind of raised up. Make sense? Am I going to give you a picture like that and say which side is the tear? Only if you want me to. Okay? And what kind of tear is it? That wouldn't be fair. I can't tell either. Okay? So, but you see how sometimes when we see tears on MRIs, especially if they're chronic, right? We tell the patient, hey, we'll get a better sense of what we're dealing with when we get there. Okay? And we'll do what we got to do when we get there. Okay? So we call those diagnostic arthroscopies. So we say we're going to do a diagnostic arthroscopy, we will take a look at it directly, and we're going to do potentially this, or potentially that, or maybe all of that. Make sense? Okay? All right. So less meniscus equals less shock absorption equals more OA. That's your adverse outcome of disease. Okay? So talking about red flags, there it is again for the 500th time if you haven't caught on to mechanical symptoms yet. Right? Ligamentous instability, that's when we're talking about ACL, PCL, LCL, MCL, right? 4 ligaments, 2 of them are intra-articular, 2 of them are extra-articular. Okay? Peripheral tears, yes. We could potentially do something about that. Okay? Especially if it's caught early, right? Where your meniscus will try to scar in over time. Yeah, so getting to them sooner is better, especially in older or younger patients. Younger patients, okay? Pain refractory non-operative treatment. So you basically done everything you can do. You called me. I said, you know, let's try some conservative care, okay? Because I think these are degenerative changes. And then you get to that point where you're like, I'm tired of talking to this patient about this. Will you send them then? 100%. Will I usually tell them that we can either do a steroid injection or we could scope for dollars? Absolutely 100%. Okay? Makes sense? Otherwise known as an ophthalmoscopic debridement after a diagnostic arthroscopy. Okay? Make sense? Okay. All right. I'm going to get into this and then we may call it. Okay? Because you got to refresh what you're applying for. Osteonecrosis of the femoral condyle. This is not avascular necrosis necessarily. Okay? Because it's not something where there's a specific decrease of blood flow. But just make sure when you're talking about femoral condyles that you understand that we're not talking about the same principles of avascular necrosis of the hip, correct? Don't get these confused. Okay? So when we talk about osteonecrosis of the femoral condyle, you see how it's just a very focal area of osteonecrosis, right? It's not the entire distal aspect of the femur, correct? It's just one aspect normally, and it's a very focal area. Does that make sense? That's why this differs. Don't confuse this with AVN of like the hip, for example, okay? But it basically means in a segment. See how it says segment? It doesn't say an entire articular surface. It says a segment, okay? It loses its blood supply. So osteonecrosis literally means bone death, okay? And that's why when you see radiographic changes, that's what you're seeing, especially if it's late, okay? We talked about this already, right? Medial, weight-bearing medial femoral condyle, right? We keep getting back to this medial condyle, medial meniscus, larger meniscus, correct? Right? But that is the most common. So I need you guys to know that. The most common is the medial femoral condyle. And can you have lateral femoral condyle? Absolutely. But the most common is the medial. Okay? So idiopathic means I don't know. Right? You don't know why it happens a lot of times. But do they have a history of some kind of systemic pathology? Alcoholism? Okay? We talked about alcoholism, right? Right? Renal transplant, chronic steroid use. Does anybody know what Gawker's disease is? Have you guys covered that yet? I'll save that then. Okay. You guys look at me like, please don't want that. All right. So who gets this? Women, 3-to-1. Older than 60. So older women are the rule, usually. Okay? Can men get it? Absolutely 100%. Okay, but the common thing is they're all over 60, but women get it 3-to-1. Good to go? All right, now these stages, do I need you to know this? I need you to understand this. Because if you have just this here in this stage there versus this divot here, so again, just this here versus this divot here, do you think you're going to see profound changes on radiographs?
Yes.
No. No. If you just have it on the left, right? So I go back to what I'm saying. I'm going to set it backwards. But if you just have this, right, you may not see that on X-ray necessarily. What's that? Yes. Absolutely 100%. Yes. So I'm answering his question, my question in reverse. So going back, right, because I might be losing myself. All right, so this here you will not see necessarily. Okay, this here you will not see necessarily, but this you will see. But once you get to, I'm sorry, and this you will see. Okay, but once you get to that point, if you see on X-rays, it's pretty profound.
Yes.
Yeah. Okay, so that's my point. Okay, good, good. Okay. I'm cold too. So subchondral collapse leads to osteoarthritis. Well, duh. If you're underneath the cartilage, you're in bone, right? That makes sense. And that's what osteoarthritis is, right? So sudden sharp pains in the medial compartment. Then I'll tell you, I had a sudden sharp pains in the medial compartment. Now, usually patients just say, my knee just started hurting all of a sudden, right? But then you ask them, like, because you guys are going to be awesome clinicians, right? So you're going to ask them one finger, point to me where it hurts the most, and they're going to do this, right? Or this, right? I can't believe I could do that and not fall over. I'm so cold. So it's going to be a sharp pain to the medial compartment. Because what's the most common condyle? Medial femoral condyle, right? Constant pain that worsens with activity. And this traditionally is sharper than OA. What is OA? Is OA kind of a sharp, achy, dull pain that they feel more so in the morning and it gets better as they walk during the day?
Yes.
Does osteonecrosis of the medial femoral condyle, does that get better?
No.
It usually gets worse, okay? Especially when they're going from squatting. I kind of dipped my toe into this topic earlier, but when they go from squatting to standing, it'll get worse because they're putting more stress, not tension, stress on the weight-bearing aspects. Okay, make sense? All right, physical exam-wise, could they have intermittent swelling? Yes. But what's the difference between swelling and effusion? Fusion involves the joint, okay, by definition, okay? Makes sense? So it's not that superficial swelling. It's like the joint swelling, okay? That can come and go. Loss of range of motion. Do you think if a patient has pain in a certain range of motion that they'll stop, maybe that they'll favor and walk a certain way, and over time they won't extend?
Yes.
Yes, so that you could have, if it lasts long enough, then you get a flexion contracture, okay? Especially if it's been present for some time without care, okay? Tenderness and palpation of the medial femoral condyle besides the patella. We'll get into patella plica and things like that, and then you'll be like, okay, by differential for medial-sided knee pain has gotten even deeper. But just understand that is a differential, okay? We'll go there later. Right? So early, you're going to see that sclerosis and that flattening of the condyle. Okay? In order to see the black arrows of death, okay, that is potentially what you may see, but usually once you see that, you know that it's more progressed, right? But initially, you may just see a kind of a sharp area of sclerosis, okay? And then later on, you get that joint space narrowing and that osteophyte formation, and that's because now that bone has died in that area. Does that make sense? So therefore, do you think that if you don't have that bone preventing collapse of that medial compartment, that you'll have actual joint space narrowing?
Yes.
Yes, and that's what that radiograph shows you there. It's supposed to correlate, the radiograph and the MRI, it's supposed to correlate. If you see this, you should think this, okay? Again, on this side, if you see this, you should think this. Because that means you have subchondral collapse. Does that make sense? It's into the bone deeper. Okay? So if you see subchondral cystic formations or things like that on an MRI report, that means it's later. Right? So MRI is confirmatory test, sure. Help identify the lesion and predict progression. What does predict progression mean? It means if you see it in a certain stage on MRI, you have a sense of like, okay, at this point, I need to make this patient 100% non-wayfaring. Do we hate that in orthopedics? 100%, because that's the enemy of motion, right? It's the stiffness. Okay? But that may be what you need to do. So if you don't do anything about it, the collapse will progress, like we talked about before. Current treatment seeks to slow this progression. Okay, what that means is, getting into this slide here, there's no great options, right? We don't have like, if you have osteonecrosis of the medial femoral condyle, you should do this and you'll be just fine. right? A lot of times, these diagnoses are not made early, right? Will patients self-limit and change their gait and change their activity level? Yes. So a lot of times they'll present. Are these patients that are younger and super active? No. So it's 60, I'm not 60, okay? But when I am 60, I hope to be doing even less than what I do now. Okay, just chilling, like on my boat from all my investment returns. But a 60-year-old, maybe it's not as active. So if you look at him and you say, hey, when you go out there and you run, what do you mean, man? I'm 60, right? I don't run, right? So they're just less active. So you can't use the same type of prompts that you use with younger active duty patients, right? So limit weight bearing and unloading braces. So an unloading brace is basically an unloading brace is usually they're custom. Okay, and what it does is they will fit them for a brace that literally causes forces that offload the medial compartment. Okay, so if you have medial compartment, what's the most common? Medial femoral condyle, right? If you have medial compartment weight bearing issues and you want to offload them, you use a medial compartment offloading brace. Okay, is there such thing as a lateral compartment offloading brace? Yes, but what's the most common? Medial femoral condyle. We'll stick with that. Okay, NSAIDs. Yeah, sure, you're going to use NSAIDs judiciously, right? These are 60-year-olds. Okay, do 60-year-olds have medication lists that look like shopping lists sometimes?
Yes.
Yes. So just make sure you assess for all their comorbidities. Steroid injections for pain. Let's talk about this real quick. It says for pain, right? Is a steroid going to cure this? Could a chronic steroid use have caused this?
Yes.
Judicious use. Okay? If I were you in primary care, would I inject medial-femoral condyle? Sorry, osteoidosis and medial-femoral condyle? No. Let us make that decision in orthopedics. Okay? I just mentioned it because it's in your literature. It's in your textbooks even. Operative. Arthroscopy, this is not scoping for dollars. Okay, this is going in with arthroscopy with a scope, doing certain things. Osteotomy, we talked about pelvic osteotomy before when it came to hip issues, right? This is breaking bone and moving things, okay? Arthroplasty, it gets to end-stage disease. You can't really do much about it at this point. We just replace the entire joint. Good to go? Okay, risk of treatment, always NSAID risk. Right? In surgery, could we ding some neurovascular structures or cause neurovascular changes that lead to further progression of other issues? Sure. Can we overcorrect sometimes because we're trying to correct those mechanics? Remember we were talking about doing offloading, right? So sometimes when there's collapse, we tend to try to do procedures that will at least give them some closer approximation to neutral alignment. Everybody knows what I mean by alignment, right? Okay. We'll get into, you guys are definitely going to have block 4. Okay. So referral decisions, red flags, failure to improve with non-operative treatment. I will tell you, even though it doesn't, bless you, good Lord, yes, sneeze bites. When you guys get into this in clinic and you have somebody with this condition, you will refer this, I promise you. Okay, but if for some reason you hold on to them because you're in an employed environment or just in a remote environment, like in the summer where I was, failure to improve with non-operative treatment, they're just not getting better. Okay, so you have to elevate. Okay, disproportionate pain. You guys remember CRIPS?
Yes.
Right? Anybody remember CRIPS? Chronic regional pain syndrome. So is this something that you might want to consider? Because isn't CRIPS multidisciplinary and you're using a lot of other medications that are not NSAIDs? Yes. Okay. That's all I have. I will see you guys next week, unless you guys stop me now and say, let's push this afternoon.